I have no financial disclosure, and I will talk about the peripheral neuropathy in AL amyloidosis. It is a common manifestation. It has an incidence that varies from 10 to 35%, depending of the cohort of patients. And the typical pattern is length-dependent, symmetrical, and lower limb predominant polyneuropathy, which is really, really painful, and which starts typically with some numbness and also with some tingling of the extremity, and then with the progression of the disease, the patient can also experience some weakness, which starts with the toe extensors and then involves also the foot extensor and eventually also the end. And this can be really severe, because some patients with the evolution of the progression of the disease can be also bedridden. Another sign which is really, really common, 20% of the patient, is the carpal tunnel syndrome, and the small fiber involvement is common and really more severe than the large nerve fibers, and it explains all the characteristics of pain that we find in AL amyloidosis associated polyneuropathy. And then, of course, we have the autonomic neuropathy, which is a severe complication and which is not simple as synonymous of postural hypotension, because we have a lot of symptoms, gastrointestinal symptoms, diarrhea, constipation, dry mouth, dry eyes, and erectile dysfunction, impotence, and of course, severe postural hypotension. I was saying before that the classical pattern is this symmetrical and length-distant polyneuropathy, but the real life surprises us, and then this is a little cohort of 14 patient French cohort. But it represents really well the reality, right? So because half of the patients of this little cohort presented with some atypical presentation, such as a painful neuropathy solely, or a lumbosacral radiculoplexopathy, mononeuropathy multiplex, or CIDP also with monoclonal kappa peak. And in this work from 2010, majority of patients were AL amyloidosis, but it was a mixed cohort, okay? There were also some hereditary amyloidosis patients. They tried to classify the patterns of presentation of the involvement of the peripheral nervous system, and the first and most frequent was the presence of a generalized autonomic failure with a polyneuropathy with a pain, and then we have also autonomic failure with polyneuropathy without pain, and all the other manifestations, for instance, polyneuropathy without generalized autonomic failure or autonomic dysfunction with small fiber involvement, they were less common. So the peripheral neuropathy can be the entry door for AL amyloidosis. So, of course, as a neurologist, I have a big responsibility, because I have to catch these patients, and the problem is that if polyneuropathy is the entry door, the delay in the diagnosis is bigger, so we'll lose a lot of time. We can lose up to 48 months for treating this patient. So what is the thing is that we have to careful and interview the patient, because a patient will not forcefully, in a spontaneous way, relate that he has dry mouth, dry eye, extremely cold feet or hands, urinary problem, fecal incontinence, erectile dysfunction. You have to ask about this, because otherwise you will miss this, and you will miss a lot of patients, because 65% of patients with neuropathy that came for the first time to the neurologist because peripheral neuropathy, so symptoms like numbness and tingling and burn feet, okay, are the first symptoms that are the first reason for the patient to go to seek medical care. But they have already 65%, they have already an involvement of the autonomic system, but you have to seek for this. So once you are convinced about the possibility that in this patient the peripheral neuropathy can be the consequence of a yellow amyloidosis, so you will go further with the analysis, so serum and urine protein immunofixation, better serum-free light chain assay, and of course, tissue biopsy. So, two things: vary the site of the biopsy. So, personally, what we do is fat biopsy, skin biopsy, salivary gland biopsy, and then of course nerve biopsy, and above all call the anatomopathologist and ask for a serial section, because you could not identify the deposit if you don't do a lot of serial sections, okay? So it is really important. Then there will be the typization of the deposit, and you have your of course diagnosis. So what about the outcome in a polyneuropathy? So a little cohort of patients, 79, no one had any stabilization of the polyneuropathy after the diagnosis. 20 years later, on a little cohort also, we have two patients that presented a stabilization, and in 2004, these are not significant results, okay, because but we have already some improvement with the stabilization of polyneuropathy in patients that were treated with autologous stem cell transplantations. And this is a study which been done on a pretty much important group of patients, 181, followed for 88 years. So we have an increase in evidence that there is an improvement in peripheral neuropathy with the regression of the disease and with the normalization of the serum-free light chain. I will skip some slides because I want to talk a little bit more about treatment issues, since this is not a good presentation. So we know that bortezomib therapy is the mainstay of the treatment for the patient, but the thing is that bortezomib can induce or exacerbate polyneuropathy. So the thing is that we have to collaborate and to work with the hematologist, so together the neurologist and the hematologist, because we have to catch these patients and to perform the electrophysiology and to have a measure of the parameters, of the electrophysiologic parameters, because if there is a worsening, this can lead to dose reduction or to discontinuation of bortezomib. So it's really important to work together and to examine this patient, especially if they manifest a worsening of polyneuropathy symptoms. And what about the treatment? So we have we do not have some guidelines for specifically AL polyneuropathy, because the recommendation they are issued from other polyneuropathies, especially diabetes. The thing is that the etiology of the polyneuropathy does not change the effectiveness of the drug, okay? But the collateral effects can be a little bit different. For instance, I would not use amitriptyline nor triptyline in patients with a yellow amyloidosis, because this can exacerbate the symptoms of autonomic neuropathy. So as first-line treatment, I use pregabalin and gabapentin, and of course always start low and go slow, so the patient will tolerate the collateral effects. The choice between gabapentin or pregabalin can depend a little bit of the patient, if there is an overweight or things like that, and then be really careful. I often organize some calls with the patients after 10 days or 2 weeks after starting the treatment to see if everything is okay. Because we have to be careful to for instance, a manifestation of cognitive deterioration, of swelling. In this case, I will drop the treatment, and I will try with another drug, for instance, duloxetine, second choice. Personally, I do not have any experience with venlafaxine, but you can use also venlafaxine, and always start really slow. I start with 30 milligrams normally with duloxetine. And then there are the topical agent. Like patches with lidocaine or capsaicin or ketamine. So do we have some evidence that this works? In literature, you will find small studies and not so much of an evidence. And my personal experience is this is really quite of an issue. And although I tried a lot, I really tried a lot to help the patient, maybe also adding the patches for the pain. But I don't know if it's because the patient may also experience some loss of dexterity, so this can be complicated to put the patches, especially capsaicin that may be administered by a nurse. And we do not have to, of course, ignore that this can be also a little bit expensive, and then there can be also high expectation from the patient. So I think that the fundamental thing is to create a cooperation with the patient and to explain to the patient that there are no drug, absolutely no drug that will lower the pain from 10 to 0. This is impossible. And this is the thing you have to say to the patient when you start the treatment. I will help you, but I won't do any miracle, because I can lower the pain from 10 to 8, from 8 to 5. So you will gain in quality of life, but I will never be able, no matter what drug I use, to put the level of the pain on the 0 level. This is impossible. Then, of course, gait aids, physical therapy, and I will add something about this. In a meta-analysis of 2021, the authors demonstrated that a lot of study where they were centered on the physical therapy, they showed how you can lower the pain and also the burden of the emotional component of the pain with physical therapy. So it is fundamental. I think that 10 to 12 weeks of moderate exercise done on daily basis can lower the score of perception of pain in patient with peripheral neuropathy and pain. Fundamental also the occupational therapy if hands are affected, and I think that the most important thing about supportive care in autonomic dysfunction is education of the patient, because education of the patient. So we will, the patient has to learn how avoid postural hypotension, postprandial hypotension, and complications such as ulcers, because the patient has to know that the shoes has to fit well. Before putting the shoes, you have to check if there is inside a pebble that can make a wound. So daily inspection of the foot. I would say monthly visit to the podiatrist. Okay, avoid self-care. And then about the carpal tunnel syndrome, sometimes we go to surgery, and this can be really, really effectiveness for the pain. I will conclude by saying that the patient with AL amyloidosis neuropathy is a complex patient, and it deserves a multidisciplinary follow-up. That's it. Yeah.